think one of the great things about the website at thespinehealth.org is that we bring together the world's top experts to provide you unparalleled access to the information that they have to share. Dr. Scott Blumenthal, our expert here in disc replacements, has traveled from Texas up to Virginia to give a grand rounds at the Virginia Spine Institute, and we're happy to capture him after this grand rounds to talk a little bit about disc arthroplasty, about what the state of the art is, what this means to patients in terms of how they get better. So, Scott, thank you for coming.
No, I appreciate you having me. Thank you.
That's very exciting to have you here and to hear all the wisdom that you have to share. So, people think disc replacement is a new concept. How long has disc replacement been around?
Well, frankly, it's been around 35 years or so. It started in Europe, and then we started doing it in the U.S. In March, it'll be 22 years in the U.S.
That's amazing. So something that people think is new has really been around for decades. And I think part of it is the evolution of the field of spinal health care, that it really has come out of these dark ages of 30 years ago and more, and now that we're getting all this technology, it's truly making a great impact. So if you were going to tell a patient what the great benefit of disc replacement is versus historically fusion, where you bind the bones together, how would you describe that to the patient as a benefit?
Basically, I like to keep things simple. What we're doing is we're reducing or eliminating pain and preserving motion. It's really as simple as that. And what that allows patients to do is get back to function, get back to what they enjoy, normal life that they feel is being robbed because of back pain.
And so when you say get rid of pain, what's causing the pain?
Well, disc degeneration, if we're talking lumbar, disc degeneration is like an arthritic hip or an arthritic knee. It's a wear and tear phenomenon, and there's a situation where a disc or two in the low back can just wear out. And before knee replacements and hip replacements, we used to fuse those joints. Now, no one would have a fusion for hip arthritis. And I think we're in an evolution for the lumbar spine from fusion for certain diagnoses, not every diagnosis, to replacing the disc.
So motion's good. I mean, we've learned that from hip and knee replacements, that preserving motion is critical for function. The same is true in the spine. But I think it's critical to state, and I'd like you to expand on this, is that not everybody is a candidate for a disc replacement.
Even in a clinic as specialized as ours, where patients come to us for disc replacement, really only about 2/3 of those would qualify. So it is not for everyone. But if you've been told that you're a candidate for a fusion, you may want to at least kind of look into it to see if you might be, because there are certain advantages.
Right. So if you talk about in the neck, let's talk about disc replacement in the neck for a minute, and talk a little bit about the evolution of that and where we are today.
So, and it's interesting you bring this up, because over the couple of decades in the U.S. of disc replacement in the neck, there's been this ongoing conversation that's gaining more and more acceptance, that if you've got a disc problem in your neck, that disc replacement is becoming what used to be the gold standard, being fusion. Now, if you have a herniated ruptured disc in your neck, again, 1 or 2 levels, most people would choose to have disc replacement rather than a fusion.
Yeah, again, motion is good. So if we can preserve it. Again, not everybody's a candidate, but when you are a candidate, it's a better option. And something that we've had experience with is combining fusions with arthroplasties, doing a hybrid when one level has to be fused, but then still doing arthroplasties or disc replacements at the next levels. Do you have any thoughts on that?
It's just like every patient we see in the office, we treat individually to their problems. We have to treat the problem of the disc individually. And if 2 discs are next to each other and one fulfills the criteria for disc replacement and one doesn't, then you've got to do what's right at each level.
Right. But the important thing for people to understand is that there can be a combination of treatments. It doesn't have to be one size fits all. So you don't have to have just a disc replacement or just a fusion. It can be combined, or you can have multiple levels and get what's right to help you get better. So what about the lumbar spine? How's that evolved?
So that's interesting, because one of the challenges of spine surgery, even before disc replacement, is what to do with back pain that doesn't pinch a nerve. So in other words, what we call axial back pain. And we've gone back and forth as to, Is fusion the right thing to do? What type of fusion to do? And then we started these FDA trials looking exactly for that diagnosis and then putting a disc replacement or putting a fusion and comparing them. And it's become one of the most studied phenomenon in orthopedics and spine. And I think we've got a good treatment in the right patient for back pain without a pinched nerve.
So, what are some of the limitations and why somebody wouldn't be able to get a disc replacement if they're suffering from back pain?
So, probably the biggest one that we test for now, and actually we test for it in our fusion patients, is osteoporosis. And in an aging population, that's something that is becoming more and more kind of on the radar screen as a diagnosis. So bone quality is one. The other one is what we call deformity, which scoliosis is perhaps a more common term, but as the spine ages, sometimes it doesn't just collapse in a straight line, it can twist a little bit. And we see a lot of that in our practice, and those patients really are not candidates for this type of technology.
So I always look at the spine as a three-joint complex at each level. You have a disc in the front, which allows for motion, and then there's two little joints in the back called facet joints that can slide. And when we do a disc replacement, we're just replacing the disc in the front. So understanding that we have three joints at each level, can you talk a little bit about how that impacts decision-making with disc replacement?
I'm glad you brought that up, because when we talk about our fractures, our spine trauma at TBI, we talk about how to treat it, and we say, well, where's the injury? Is the injury in the front of the spine, or is the injury in the back, or is it both? In which case, sometimes you have to go in the front and the back. So if you've got a degenerative condition and all the problem or most of it is caused by problems in the back, putting a disc replacement in the front is not going to correct that. You've got to go where the action is.
One of the key things is talking about how long these disc replacements last. People have a hip replacement and they understand they may need to have it revised at some time, or a knee replacement may need to have it revised. Can we talk about how long these disc replacements will last in people?
So two things that make disc replacement different. So number one, we've had the benefit of the materials that have been used for hip and knee replacements that now make hip and knee replacements last longer than they did 50 years ago. So we've got the most modern materials. And then it's the joint. The disc just doesn't move as much as a hip or knee, so there's less wearing out. So we're really not seeing the need for revision arthroplasty like we do in hips and knees.
What kind of lifespan would you give an implanted disc replacement on average?
The disc replacement doesn't prevent the cumulative aging process. So in other words, all our discs will kind of show signs of wear and tear. The disc replacement will treat the symptoms as they are now, but your spine's still going to be 10 years older in 10 years. So it's not that the disc replacement wears out, it's just that you get more arthritic as you get older, and the disc replacement just doesn't move as much.
What words of wisdom do you want to share with the public about disc replacements and their overall picture and understanding whether they're a candidate for it or whether it applies to them?
Well, the simplest thing is whether it's in the cervical in your neck or the lumbar, if you've seen a surgeon and been told that you need to have a fusion, look into disc replacement. It is an option, and not every surgeon offers that or does that. So, and it's pretty easy these days with the internet, with telemedicine, to get an opinion. And we tell all our patients is, get a second opinion if it's truly elective. I think that's rational for anybody. I'd get a second opinion if it was had a problem not in my field and it was looking at a serious surgery.
One of the things to understand is that disc replacement surgery is technically more demanding than a fusion surgery. Not that either of them are easy, but you have to be much more precise with a disc replacement to make sure you get the right balance, the right alignment, because now we're putting motion in, and it's important to have the implant in the right spot. Can you talk a little bit about the complexity difference of the operation and need for accuracy with disc replacement versus a fusion?
Since the disc replacements move, they need to be in what's called the correct center, so that we talk about instant axis of rotations and and arcs and things like that. So that depending on the makeup, depending on the brand or the model, they all have a different place where they need to be. And we're pretty specific in surgery in terms of placing them because they really have a tolerance of anywhere from 1 to 3 millimeters, and if you're more than that off, it's not going to work.
I think one of the interesting things is that disc replacements from 35 years ago, from 20 years ago, are very different than the ones we're doing today because of the evolution of the technology. Can you comment a little bit about how the implants have evolved and why today's are better than prior ones?
So I'll touch on both. So in the lumbar spine, the second or the next generation disc replacements were evolutions from the first generation. What worked about the first ones and what didn't work, and so that went into the design of the one that we're using currently. In terms of the cervical spine, we're seeing material changes as well. So new materials, new sizes, and better imaging. So they're both moving along. Cervical is probably moving along quicker because more people are using it, and it's probably applicable to more people. But they're both better than they were 20 years ago.
Yeah, I think that's a huge difference is the variability in size. So that the early ones were more one size fits all, whereas now we have much greater variability, especially in the cervical spine.
Absolutely.
And so we can really custom size an implant, so you can fit a tiny woman or a huge guy and still get the right size implant, which with some of the earlier designs was a problem. Scott, here's a question that comes up from the public is, if you had one of the older first generation disc replacements, an older implant, should you get it revised to a newer one?
And this is really only applicable to the cervical spine. We have seen some cervical discs wear out, the older design discs, and those can be replaced. If it's not causing you any symptoms, no. Don't leave well enough alone. But if there's an issue with the disc that's causing symptoms, then it can be replaced.
Looking into the future, we've seen such a great technological evolution over the past several decades. Should patients wait to get their problem treated at some distant time in the future, or is it the time right now?
Well, again, two separate questions for the lumbar and the cervical. If you wait too long with the lumbar, your disease may progress to the point where you're no longer a candidate for disc replacement. Cervical, I think, with 7, 8 on the market, I think we're pretty good. I don't think there's any reason to wait for cervical.
7, 8 what?
Different discs on the market.
Right.
And lumbar, the discs that are out now are very, very effective. And if you wait too long, you might not be a candidate anymore.
Yeah, I mean, the cervical spine has gone through many more generations of devices, and we truly have some great implants out there. The lumbar spine's also gone through generations, and the ones there are very successful. And so the way I look at that question is to say, you get surgery when you're having problems that are impacting the quality of your life. And if you can't live the quality of life that you desire because of a spine problem, then fix the spine problem if you can fix it. Non-operatively if that's possible. But if you need surgery, then use the best technology. And that's what Dr. Blumenthal has shared with us today is where the state of the art is in disc replacement treatments. I think it's important for the public to know that the National Spine Health Foundation is your go-to place for information on spinal health and what treatments work and what the best options are for your health. And we'd like you to visit us frequently to find the answers to your questions about your spinal health.